about my work. Can everyone hear me? Yeah, great. Okay, so my research really has two streams. The one is, all of it focuses on substance use. One stream focuses very much on vulnerable populations, but I'm not going to talk about that today because I'm talking about it tomorrow, and some of you might be attending the conference. What I want to talk about today is my health system strengthening work, focused on the substance abuse treatment system, and about what can be done to narrow the very large treatment gap for substance use disorders. So today I'm going to cover, I'm going to give you a little bit of context about Cape Town and South Africa and why addressing substance use disorders is important in this region. I'm going to describe the treatment gap and barriers to treatment initiation. And then I want to talk about two treatment strengthening efforts. The first is focused on improving the availability and range of services for people with substance use disorders, and particularly around screening and brief interventions and referral to treatment. And the second is focused on efforts to improve the quality of services. And then I want to talk a little bit about some of the lessons we've learned from these implementation efforts. So I don't know how many of you have heard about Cape Town or know much about Cape Town, but Cape Town, I want to talk a little bit about, tell you a story about two cities. There is the Cape Town that many of you may have heard, you might have even visited, and that is a beautiful place that has one of the 7 natural wonders of the world, being Table Mountain, pristine beaches, wonderful winelands, fantastic hotels, good dining, and it's the Riviera of Africa. But there's an underbelly to Cape Town that many people don't see. So sort of under the shadow of the mountain, there's another side to Cape Town, where many people, in fact the vast majority of the population, live in areas called townships, which are characterized by very high levels of household poverty, where the vast majority of people live under the breadline. The picture on the top left, see that? The picture on the top left is a place called Blikkiesdorp. In Afrikaans, blikkie means a tin, and so these are tin shacks that have been put up for temporary housing, but people have been living in these tin shacks and sandy streets for more than 10 years. And coupled with this poverty, lack of adequate housing, there is a lack of sanitation, very few economic opportunities, food insecurity, and this inequality and lack of socio-economic opportunities is a breeding ground for all kinds of health problems, including substance use disorders. So particularly in these poor communities called townships, there really is a concentration of intersecting health and social problems. In fact, South Africa, we have a quadruple burden of disease. We have, as I'm sure many of you know, amongst the highest prevalence for HIV and highest incidence of new HIV infections globally, and accompanying that also very, very high levels of TB. We also have, with the advent of ARVs and people living for longer, we also have a growing problem with non-communicable diseases, particularly hypertension and diabetes. And we have very high levels of injury and violence. And underpinning this, substance use and other mental disorders are a problem, and they complicate the treatment of infectious diseases and non-communicable diseases, and are themselves a risk for injury and violence. So what is the prevalence of substance use disorders in this region? In South Africa, there's a lifetime prevalence of substance use disorders that it's estimated to be around 20%, around 13%, sorry, in South Africa. But that's nationally, but provincially in the Western Cape, so Cape Town is the capital of the Western Cape, it's, the lifetime prevalence is around 20%. South Africa also has globally amongst the highest rates of per capita alcohol consumption per drinker, as well as the highest rates of heavy episodic drinking per drinker globally. Methamphetamine is entrenched in many communities in the Western Cape, and there's also an increasing use of heroin. So really a lot of substance use problems in communities. Yet despite all of these problems, very few people ever access treatment. Christina's one study showed that amongst methamphetamine users in communities, more than 90% met criteria for severe substance use disorders, but less than 10% had ever accessed treatment. So why is Cape Town so affected by substance use disorders? Well, there are multi-level influences on the prevalence of substance use disorders. At a societal level, we've got a very sad history of alcohol being used as part payment for farm workers and labourers in our region. We have a very large agricultural and we are a wine-producing region. And so historically, farm workers were given a dop or a tot of alcohol as part of their weekly wages. And this set up communities and families with alcohol-related problems, and perhaps it's partly genetic, perhaps it's social learning, but we've got the use of alcohol is normative. Heavy alcohol use is normative in this region. At a societal level as well, there's a widespread availability of other illicit drugs, and this is partly because of poverty and where drug trading and the role and gangs have emerged as a way of creating an alternative economy for people who can't participate in the formal economy. At a systemic level, we have an underdeveloped treatment system for substance use disorders. And so even if people want to access treatment, they struggle to do so. Also, factors like peer networks and social norms that are supportive of substance use, as well as violence and stigma around treatment seeking, all impact on the use of services. And then at an individual level, there are factors such as readiness for change and readiness for treatment, stigma around treatment seeking, as well as trauma and other mental health problems that complicate the picture. This picture over here is a picture of farm workers being paid their weekly dole. So what is this gap and how large is it in terms of treatment seeking? So community studies have shown that there is actually a very high level of recognition of the need for treatment and treatment readiness. In fact, the rates of treatment readiness amongst non-treatment seeking, amongst people who are not seeking treatment but have substance use disorders, was higher in Cape Town compared to the US. Yet only 5 to 10% of people ever receive any kind of intervention for their substance use. And the gap is much worse for women and for people of color. So why are people not accessing treatment? A lot of my initial work was trying to understand the barriers to treatment initiation amongst vulnerable populations. And there are many barriers, but they can basically be grouped into 4 categories. The first category is systemic barriers that relate to the limited availability of services, and I'll talk a bit about that later, as well as a limited range of services available. So we have some residential programs, which we call inpatient programs, and we have a few outpatient programs, but there are no early intervention programs, and they're limited aftercare or continuing care programs. Also, services aren't comprehensive, so they'll address substance use, but they won't address the myriad of other intersecting problems, particularly for women, where women come in with a complex range of health and social problems, often including childhood sexual abuse and perhaps physical abuse from partners. But the trauma doesn't get dealt with in the substance use system. The health problems don't get dealt with in the substance use system. Our substance abuse system is substance abuse services are provided by our Department of Social Welfare, and the Department of Health would deal with HIV, the NCDs, injuries, mental health gets dealt with there. So we really have a very siloed approach to dealing with substance use disorders. The second category of barriers relates to concerns about the effectiveness and quality of services. So people, even though they want to go to treatment, don't believe that treatment will work, and there are a lot of anecdotal reports of punitive practices, mistreatments within treatment centres, and that people go to treatment and they come back and their problems are just worse rather than better. And although things have been improving over the last couple of years, we still have a lot of services that don't provide evidence-based treatment. So some of the provinces, there's a push towards delivering evidence-based care, but for the vast majority of the country, we still have really outdated models of treatment. Thirdly, there are a lot of structural barriers that particularly poorer people experience, and these are related to the geographic location of services. So sometimes services are sort of in very far-flung parts of the province. It's a lot of transport costs to get to services. Competing priorities that they need to provide for their families and look after children rather than go to treatment. And also, not being able to afford the affordability of services as well. And then there are a lot of individual level barriers around limited awareness of not only where to go to services, but the process of accessing services, a lack of social support for treatment seeking, and also a lack of social support for abstinence. So that there's a lot of pressure once people go to treatment, when they come back, a lot of pressure to sort of take up that old drug-using lifestyle. Stigma around being identified as not so much as a drug user, but as a person who couldn't control their drug use. And as I mentioned, also a lot of competing priorities. So what I want to focus the rest of the talk on is efforts to address the first two categories of barriers. So first of all, I want to talk about efforts to improve the treatment availability and range of services. So this is a map of South Africa, and what the map depicts is the number of residential and number of outpatient services available. Now, we're a country of 55, the last count was about 55 million people. And as you can see, that some of the provinces actually have no treatment services available, or they'll only have one treatment service available. In the Western Cape, we treat on an annual basis about 4,000 people. The numbers vary, maybe it's a little bit more, between 4,000 and 6,000 people. We not only treat people from our province, but also from other neighboring provinces where there are few treatment centers. So there really is a limited availability of services, and treatment is only catching the sort of a very small percentage of people who could benefit from treatment. Most of the services that are available are high threshold services, and there are no early intervention services, or very limited early intervention services available. So we're interested in expanding the range of services and narrowing this treatment gap.
Bronwyn, does that include private services as well, and faith-based services?
Yes,
so this
includes
is
everything.
gamut.
What it doesn't include is what we call the mom and pop services that might be treating 2 or 3 people. You know, they're not formal services, but there are individuals in communities who might be providing some support or care that we're not aware of. But these are, if you're looking for a place to send somebody, you have a list of facilities. This would include that list. I should say we'd be significantly better off than many other African countries. So it's all relative, but for the extent of our problems, the prevalence of our problems, we're really only capturing the top of or the top layer of people with substance use disorders. Now, part of the problem is that building more facilities is hugely resource intensive, and we just don't have the money. But the thinking is that if we can expand the range of services to include early intervention or low threshold services, where we can detect people when they first start having problems, before they progress to having a severe substance use disorder, we may be able to halt the progression of these disorders and prevent the need for sort of residential treatment. So what this diagram, this pyramid shows is an optimal mix of services for, it's borrowed from the World Health Organization's optimal mix of services for mental health, but it can apply for substance use disorders as well. And it suggests that really screening and brief interventions and services that are provided within the primary healthcare system and within community settings can really make up the bulk of services available, and that only those individuals with much more severe substance use disorders should be accessing outpatient and residential care. So what is screening, brief intervention, and referral to treatment? SBIRT programs are early intervention services that are often delivered in primary care settings. And the purpose of these is to detect individuals who may not be treatment seeking, but who may be displaying problems largely with alcohol, but also with other substances. So they might be drinking at risky levels, and they might be starting to have health and family problems or work problems. So it proposes that everybody coming into a particular setting is screened, so universal screening, using a brief validated screener. Those who are above the threshold on that screener are provided with a brief intervention, which can be between brief advice lasting for 5 minutes to or between 1 and 4 sessions of an intervention. And then individuals who are at high risk for substance-related problems are then referred to ongoing care. Does it work? There's a lot of evidence, at least from high-income countries, that SBIRT is very effective for reducing alcohol-related problems. The evidence is a bit more equivocal for drug-related problems, but that certainly it does show effect for alcohol-related problems. So the question is whether it is useful and it's feasible to implement in a primary healthcare setting in South Africa. But generally, it's thought that these interventions can improve the detection rate, so it can capture more people who have potential alcohol and drug-related problems, can expand coverage of services in a cost-effective way, and can also, if they're provided in primary care clinics that are available in each and every community, can also reduce geographic access barriers. And then, depending on where the services are offered, can possibly reach people in a teachable moment. So if they come into the emergency departments and have an alcohol-related injury, they might be open to thinking and talking about reducing their alcohol use. One of the challenges in adopting and implementing SBIRTs in a lower resourced setting is that we do not have the healthcare personnel available to us that is often available in a higher resource setting. So what we're thinking about as a country is task shifting. So healthcare resourcing is a major constraint in South Africa. What this table shows is the number of, by staff category, the number of personnel per 100,000 population available in the public health sector. And so mental health specialists who would be perfect and who might be used to conduct SBIRTs or psychosocial interventions in the US are really not available to us in South Africa. So, I mean, we have less than 0.2 per 100,000 for psychiatrists, and even nurses in psychiatry, so psychiatric nurses, 10.8 per 100,000. So we've been thinking about how can we how can we use other levels of or generalists to deliver these kinds of interventions, and can they be trained? So basically what task shifting refers to is shifting a task that would have been within the job description of a mental health specialist to a generalist. And there are 4 levels of task shifting. You can task shift to a general practitioner, a doctor, to a community health nurse, to a community health worker, or to a person who's living with a disorder. For task shifting to work, though, the specialist would have to provide a lot of supervision and support to the generalist. So task shifting is a very popular buzzword in South Africa at the moment, and in fact our new mental health framework, which you might hear about tomorrow, is it's really supportive and embeds task shifting in its breakdown of what kind of services need to be provided in order to reduce the mental health treatment gap, as well as the gap for substance use disorders. Because substance use disorders is intertwined with and embedded in our mental health policy framework. So there have been several attempts and efforts to introduce screening and brief interventions and referral to treatment into various kinds of services which are delivered in primary care clinics in South Africa. And I'm going to talk briefly about 4 examples of these programs. A program in the psychiatry outpatient service, a program in emergency departments, in antenatal care, and then in chronic disease care. And all of these programs adopt a task shifting approach. So the first project was conducted at a hospital called GH Worcester, which unfortunately the hospital is now closed, but it served the catchment area of Mannenberg, and Mannenberg is at the moment is in the middle of a gang-related drug war that's gang-related. It's a community that's sort of riddled with health and social problems, particularly around drug use and violence and trauma. So, an epidemiological survey in this hospital found that 80% of patients that were accessing psychiatric support services on an outpatient basis also had comorbid substance use disorders, but there was nowhere, they weren't being treated for the substance use. The substance use was just being ignored. And so, the hospital created a substance use hub where they wanted to conduct universal screening and provide patients who they detected with a substance use problem with an intervention and referral to ongoing services. So the plan was to conduct universal screening, nurse-led universal screening of patients. The patients who were identified as being at risk of a substance use disorder were referred to the center, were re-screened using the ASSIST, which is a WHO screening instrument, and then patients who were above the threshold were provided with a brief motivational intervention. And one session, high-risk patients were then referred on to an outpatient substance use service. And we conducted a 7-month evaluation of this program. What we found was that instead of universal screening, there was case finding. So the nurses conducted case finding. So they only screened patients who they suspected they were acting oddly, or they smelt of alcohol, who they suspected or knew to be using substances. We also found that this was a really complex population. More than 2/3 actually were in a high-risk group and needed referral to treatment. Despite this, over the course of the program, patients who received the intervention did show significant positive reductions on their substance use involvement. Unfortunately, what we also found was that the referral pathway broke down. So for those 2/3 of patients who needed referral to additional care, less than 50% actually took up the offer of treatments. and they reported, those that did not take up the offer of treatment reported a range of attitudinal and structural barriers. So they didn't want to go to treatment because they thought treatment wasn't going to work, or they thought they could deal with their problems by themselves, but also they had real logistic barriers to get into treatment. Sadly, of the patients that actually did go to treatment, only 55% were satisfied with the services that they received. So I want you to remember that, because we're going to talk about satisfaction with services a bit later. So we also conducted SBIRT in emergency departments. In South Africa, emergency departments are linked to, so there's a trauma unit linked to every primary healthcare clinic. And there are 24-hour services where people, mainly with injuries, would present with injuries, but also people present over the weekends and after hours with other health-related problems that need to be seen to outside of clinic hours. So alcohol plays a major influence on how these emergency departments operate. So particularly with injury, the vast majority of patients who arrive being injured are injured because of interpersonal violence, and somewhere in that, alcohol generally plays a role. Either the perpetrator has been drinking or both parties have been drinking. So the busiest times for the emergency departments are over weekends and on paydays, because that's when people like to drink. So we followed, and I want to talk about this briefly because these are the steps that we always follow in developing or adapting an intervention. So we follow the following steps for developing an intervention that we hoped would work in an emergency department. First of all, we conducted a survey to really try and understand what are the mechanisms that contribute to people using substances. And what we found was that, or not stopping using substances. And what we found was that problem solving, social problem solving, and readiness to change were some of the major factors. We conducted in-depth interviews with emergency department personnel and health workers to try and understand what are the barriers to implementing an intervention in these settings, and how could we adapt our ideas about a SBIRT-type intervention to work in that setting. We had experts, stakeholder meetings where we presented our ideas and asked for inputs so we could refine our intervention. And then after adapting an intervention and implementation protocols, we pilot tested the intervention with 20 patients before we went to a small trial. And this is our intervention booklets picture. And the intervention that we used in this setting was a blend between motivational interviewing and problem-solving therapy. Problem-solving therapy, was a 5-session intervention. The first session was purely motivational interviewing. The remaining 4 sessions were problem-solving. And problem-solving therapy really focuses on helping people identify what's important to them in their lives and what prevents them from reaching these important goals, and then trying to help them identify the problems that prevent them from reaching their goals, and categorizing these problems into problems that are important and can be changed, problems that are important but cannot be changed, and problems that are really not important or don't interfere with them reaching their goals. And then the intervention helps people develop strategies for dealing with each of these categories of problems. This is the study design. It was called Project Strive, and it was a small randomized controlled trial where individuals were randomized to one of 3 interventions, either 1 session of motivational interviewing, a control group where people were just given an information booklet, pamphlets, or the blended motivational interviewing problem-solving therapy. And as it might be hard to read the slides, but small, but we screened a lot of people for eligibility, and through the intervention, we also had quite a lot of dropouts. The high attrition rates is because it was a pragmatic study. It was funded by our Department of Health, and they really did not want us to track and follow up people, because they wanted to see what would be sort of the uptake of the intervention. So we did have some very interesting findings. We screened more than 2,700 people. Of these, 19% actually met criteria to be in the study, which showed that there is a need. And 74% of those who were eligible were actually interested in receiving an intervention. So that was quite promising for us, so it shows that there's some acceptability. In terms of the feasibility of a 5-session intervention, we learned that this was actually just too long for patients to come backwards and forwards to the healthcare clinic to receive additional sessions. 58% completed all 5 sessions, and the patient feedback suggested that 3 sessions would be much more feasible. However, they did really like the intervention and thought it was helpful. Did it work? Well, at our 3-month, we had a 3-month follow-up, and at our 3-month outcomes, everybody, irrespective of the intervention condition, people's substance use decreased. However, people who were randomized into the blended motivational interviewing problem-solving therapy, their substance use involvements decreased the most. We collected our outcomes. Our primary outcome was substance use involvement, but we had a secondary outcome of depression as well. And what we found was that when we compared the arms, those participants who were randomized to the motivational interviewing arm, when compared to the control group arm, that group that just received a pamphlet, there was actually no difference in the extent to which their substance use involvement decreased, and no difference on their depression scores at 3-month outcome. However, when we combined the motivational interviewing group and the control group into a larger control group, and compared against our intervention or experimental condition, we found that individuals in the MI-PST group had much greater decreases in their substance use involvement and their depression scores than individuals in this combined control group. We also did a cost-effectiveness analysis, and we found that the MI-PST condition was much more cost-effective than MI or the control group alone. So certainly promising. And what the slide shows is the kinds of participant feedback that we got. We conducted qualitative interviews with 20 participants who completed the intervention, and they spoke about how the problem-solving component had really been useful for helping them sort of stop avoiding their problems, and also to find more useful ways and helpful ways of coping with their stress. So what's next from an emergency department perspective? We have 2 initiatives underway. We've got a new study which is focusing on expanding this program for adolescents, and it's really in the inception phases at this point. And very exciting for us, the Western Cape Department of Health has bought into this project and into this program, and is supporting the initial rollout in 4 emergency departments of SBIRT, of Project Strive. So they're rolling this program out in 4 emergency departments, and they're going to be using emergency department staff or lay counselors at the facilities to actually deliver the intervention. So they've built it into their policy and into their service plans, which is really important when thinking about moving a study from the field into practice. Okay, so very briefly, I want to talk about another initiative to introduce SBIRT into antenatal care or prenatal care. Prenatal care in South Africa is also delivered in primary healthcare clinics in what we refer to as MOUs, which are midwife-run obstetric units. so completely run by midwives. These are places where women in communities come for all of their antenatal care. They present to be tested for whether they're pregnant, and they make what they call a first booking visit, which is a date for delivery. And then they come for various appointments at various stages of their pregnancy. In an average month, facilities will receive 650 first bookings. There will be 2,200 follow-ups, 300 deliveries. Women deliver these uncomplicated pregnancies, also deliver at these places. So these are very, very busy places. So the target population, the women who use these services are usually from low-income areas, and we have a very high rate of fetal alcohol spectrum disorder, sadly, in the Western Cape. So, and very high rates of smoking in general, but smoking in pregnancies is also very high. So this was a community health worker delivered intervention, piloted at one very busy MOU. Here, the nurse who does the first booking or the intake history for women conducted a very brief screener, basically asked, do you screen for depression and for tobacco use and alcohol, and then all women would be referred to the HIV counsellor who is present at each facility, who does HIV testing and counselling, and also counselling around prevention of mother-to-child transmission of HIV. And this HIV counsellor would then conduct the assist again, as well as the Edinburgh scale for postnatal depression or prenatal depression, and women who scored high on the assist or who reported any drinking would or tobacco use would receive an intervention called the 5 A's, which is also loosely based on motivational interviewing and has been shown to be effective on tobacco. Any woman who met above the cut-off score on the Edinburgh scale for depression would then be also referred to a psychological counsellor for further ongoing care. So, in terms of what we found was the results were not so promising in this setting. Only 43% of women who were presenting for their first booking were screened, despite the very high rates of alcohol and smoking in this population. And we also found unexpectedly low rates of disclosure, that only 26.4% of women disclose tobacco use, and we know that the community prevalence is much higher, and only 2% disclose alcohol and drug use, which is also, for this community, very low. We think it's because of who conducted the screening and where it was located, with women being really concerned about being stigmatized and mistreated because they were pregnant, and the stigma of using while pregnant. In terms of preliminary responses to the intervention, there was some promising decreases in tobacco use that were significant, but a very small sample, but there were no significant reductions in alcohol use. Perhaps we didn't have the power because it was such a small sample size, but it could also be that this 5 A's was really designed for tobacco and had just been applied for alcohol use, and maybe it wasn't enough. We explored through qualitative interviews perceptions of barriers to implementing and delivering SBIRT in this setting. And one of the major barriers was that the nurses and the staff in this facility really felt that this increased their workload. The staff that had been trained to deliver the intervention, there were large gaps because they would be absent, and then there would be no one to deliver the intervention. And also the way that it had been integrated into the facility, it was less than ideal. People hadn't been properly consulted or trained, and so the entry process was problematic, and it really resulted in resistance in terms of healthcare staff delivering this intervention. So I want you to keep that in mind when we talk about lessons learned too. So, and the final program I want to talk about is SBIRT for mental health, broadly in chronic disease care, or Project Mind. So Project Mind focuses on providing services for alcohol and depression in a sort of a trans-diagnostic kind of intervention in the context of chronic diseases, particularly HIV and diabetes. Because in our setting, HIV is seen as a chronic disease now. These problems are important to deal with in the context of chronic disease care because we know that untreated mental health problems impact on adherence to treatment as well as chronic disease progression and response to treatment outcomes. But at the moment, because of our very siloed healthcare system, there is very little screening for mental health problems in the context of HIV and diabetes and other chronic diseases, even though we know that the prevalence of these problems is really high amongst this patient population. So Project Mind is an initiative to try and integrate, bring closer together care for mental health problems, particularly common mental disorders like alcohol and depression, within the context of chronic disease care. So this is the outline of the project. It's a 4-year project. The first phase has been a health systems analysis where we've really tried to understand how mental health services and chronic disease services are structured in the Western Cape and delivered, and what are the potential barriers and facilitators to implementing a new program for mental health within the context of these busy services. The next phase is going to, we've just finished this phase. The next phase is going to be a trial where we're going to be testing 2 collaborative care approaches to delivering mental health care against treatment as usual. And at the same time, we are going to be conducting a process evaluation to understand and extract implementation lessons. And finally, there's going to be a feedback phase or action research phase where we're going to go back to each of the healthcare facilities and train them on the model that's been shown to be most effective and try and support them to implement this model. So what we've learned is that there are many factors that impact on facility readiness to implement screening and brief intervention or a new program. There's a lot of variability around within these primary healthcare facilities, but some sort of higher level lessons can be extracted. And the one is that leadership and governance is key. So facilities that have really strong leadership and a participatory leadership where they include and they communicate with their staff members and each of their the services that are provided in those facilities have a much more open attitude to new programs. Facilities where the leadership is weak or transient and have new leadership coming and going and it's unstable and have very loose governance structures really are a little bit too chaotic to implement a new program. Secondly, culture, organizational culture or facility culture is really important. The work ethic of staff varies from facility to facility, and also pride in the kinds of services that they provide in their facility and how they take care of their facility and the atmosphere in the facility and the morale of staff. All of these factors also impact on readiness to implement a new program. Thirdly, communication. Communication is one of the essential things. It's essential to successful implementation. So we've spent a lot of time trying to communicate with the right gatekeepers to get buy-in for this and market our intervention and our program. However, the communication channels are very complicated. Sometimes you think you're communicating with the right person, but they don't communicate with the rest of the staff. And so where there is not good communication channels within a facility, or where there isn't good communication channels between facilities and sub-district management teams and provincial management teams, the whole process can sort of break down. So a lot of our work has been to try and layer on. We've been doing the work of the departments in terms of creating good communication channels. But this is a lesson that we've learned. And The fourth factor that's really important is the availability of person-centered care. So, unfortunately, some facilities still have person-centered care is completely lacking. So we've witnessed patients being screamed at and degraded in public. We've witnessed lack of confidential care where they're being tested in a room where there are other people with earshot, or people with diabetes are having their feet examined in a waiting room. And some of this is about infrastructural issues, but a lot of it is also just about forgetting that patients are people. The humanity is lost a bit. On the other hand, there's some fantastic facilities that are really, there's warmth and person-centered care is high on the agenda, and those facilities are the ones that are really open to implementing mental health interventions. But there are also, these are facility level factors, but broader than that. There are other community and environmental factors that also impact on the extent to which facilities are open to implementation. And many of these facilities are located in environmental contexts where there's high levels of violence, so staff actually feel threatened coming to work and are working under huge amounts of stress and have been traumatized themselves. And also infrastructural and resource challenges, particularly in the rural facilities where there are unfilled posts and people are doing multiple jobs and are juggling multiple responsibilities. So they feel so very thinly stretched. So what are our collaborative care models? That we have taken all of the responses of the healthcare system and we've developed two collaborative care models. A dedicated approach and a designated approach. The dedicated approach is we are going to be adding a lay counselor to the chronic disease care team. So in this approach, the whole chronic disease care team would be trained and sensitized around mental health care issues. And we'd also layer in regular case discussions to talk about mental health to make it a priority. And we would work on building referral pathways between the chronic disease care team and the mental health services. But we would layer in an additional person whose sole responsibility would be to deliver mental health care and support. Our second approach is the dedicated approach, where we would do all of these things that I've just described, but instead of layering in a person, we're going to be identifying one or two people to be trained to deliver this mental health care package in addition to their usual care duties. There's been a lot of backwards and forwards between our stakeholders about which approach they think would work best and which is going to be more efficient within the healthcare system. But at this point, there's equipoise. Some facilities think they would like an additional person. Some people think that it's just not feasible financially to add an additional person to the team. We've decided to use community healthcare workers who are like lay counselors because nobody else in the team, the nurses, the doctors, have the time to deliver an intervention. So what will the intervention look like? So instead of a 5-session intervention, we've learned our lesson. We've got a 3-session intervention, which is highly structured. We provide patients with handouts and booklets available in all 3 of our local languages. But it also includes case management. Case management does happen as part of HIV and diabetes care anyway, so it would just mean a little bit of additional case management for patients who are identified as being at risk for depression or alcohol problems. And an additional booster session. So what lessons have we learned from this SBIRT research? We've learned that universal screening is lovely to have, but it's just really not feasible, and that case detection in our context might just be a more efficient way of detecting people who might benefit from SBIRT. We've learned that SBIRT has promising outcomes, but really we do need more research with longer term outcomes to make a stronger case for investment in these services. We've learned that SBIRT can be task shifted, but the task shifting seems to work best when the intervention is highly structured. From our emergency department work, we believe that the motivational interviewing didn't work well because we used lay counselors. And motivational interviewing is a very difficult skill to teach people who have low levels of education, and you might not be that way, naturally that way inclined. So a highly structured, manualized kind of intervention seems to work a lot better. We've learned that it can be implemented in the healthcare system, but there are many challenges to implementing a new program that needs to be considered before rolling out and investing in the program. In fact, we've got there's a long list of interventions and wonderful ideas that have been proposed and invested in, but they just haven't taken root in the healthcare system because these implementation challenges haven't been fully thought through. And then we've also learned that referral to treatment really, this part of the chain really does need to be strengthened. And part of that is ensuring that that available treatment is acceptable to patients. I was going to talk about the work to strengthen the substance abuse treatment system through introducing a performance measurement system to monitor the quality and effectiveness of services. But I'm looking at the time and I realize I don't have time, so I'm not going to cover it. I'm going to skip to the long slides. I wouldn't be able to cover it at all. Wow. Always have a lot to say. So I want to spend the last 5 minutes talking about the implementation lessons that we've learned through this process. And the first implementation lesson we've learned is that it really is very difficult to work in the healthcare system. There are many obstacles in terms of approvals and finding the right gatekeepers. And what I've had to do is to make peace with the fact that via research, the timelines have needed to shift a lot. There's been a lot of delays in timelines. So you almost have to suspend your thinking as a researcher and accept that working in the healthcare system is full of obstacles. I've learned, as I mentioned earlier, that continuous communication is key. That I can't sit in my ivory tower in my office. I need to be out there, constantly talking to people. And as part of that is building relationships with gatekeepers, and not just the decision makers and the planners, but also the people in the healthcare facilities who are also gatekeepers. Marketing of the program is really important. People change in the healthcare system all the time, so marketing is not just a once-off, we're starting the study, but it has to happen on in a continuous manner. And part of that is also branding. You're selling a product, and it needs to have branding and logos and be colourful, and so people remember what you're selling. Sometimes you talk to someone and you say, I'm going to set up an appointment, and you go to them, and then you have to tell them over again because they've forgotten about what your project is about. So it's a continuous process. Learning the procedures and the rules and the bureaucracy of the healthcare system is also important if you want things to go smoothly. Sometimes the officials in the healthcare system don't even know the processes themselves, so it's useful just to check with everyone that you're following the right process. And then also the people who are actually implementing, the healthcare providers who are implementing this program often work in really difficult contexts. They don't always get the support from their team and from the management of that healthcare facility that they need, so providing them with continuous support is important. And also to be mindful that as an implementation or services researcher, my primary focus might be research and getting it done, but the implementer's primary focus is providing clinical care. And so it's my job not to be a burden to them and to be useful. So that's also quite a mind shift. So those are some of the implementation lessons that we've learned so far. I'm sure there are going to be many more. So it's difficult, but there's a reason why and challenging, but there's a reason why we do it, and that's because there really is no health without mental health. And if you have a substance use disorder, you don't have good mental health. So this is why we do the work, is to try and really make a difference and improve the lives of patients. So thank you, and I've spoken a lot, and I'd be really happy to take questions.
Say a little more about the adolescent health system. I mean, you're going to start to work with them. Are they in the same system?
That's a really good question. For the most part, yes, they are in the same system. So everybody, poorer people in South Africa who don't have medical insurance, all access our public healthcare system. And the first port of call are these primary healthcare clinics, which are located in every community. For the most part, adolescents would just access these services. In the city of Cape Town, we have two or three sexual and reproductive health services that are adolescent specific, with adolescents being defined quite broadly, so up until the age of 24, including the age of 24. But these are just 2 or 3 clinics. I don't know whether the plans are to expand these more broadly. So it's, as you can imagine, these services, in general, our primary healthcare services for adolescents can be quite daunting, and from my work with adolescents, they really don't access services until they really have to. Yeah, it's just, they're just not particularly friendly. Adolescent mental health services and substance use services are in a bit of a sad state. So in the substance abuse treatment system, adolescents are treated for the most part in the adult system. We had one residential facility for adolescents in the Western Cape, which was closed because of all kinds of problems. And now those services have been integrated into what are called schools of safety for adolescents who have had problems with delinquency. So these are really kids who have already had trouble with the law and who are actually very troubled. And so adolescents just with who have been caught using at school or in their families are referred into that same system of care and are mixed with adolescents who are a lot more troubled. So it's quite a disturbing picture, and there's a lot of advocacy work which is happening to try and separate out these two systems. It's not a healthy place for young adolescents to be in.
First of all, thank you for talking to us about your work. My question is with respect to the patient satisfaction that you mentioned. If you could just talk about how you defined it and then what aspects of it you looked at and the implications of the results.
Okay. So, so we've got a performance measurement system that has been several years in the making, and that collects patient-reported outcomes on substance use outcomes, social connectedness, quality of life, HIV risk behavior, and perceptions of quality of care, which patient satisfaction, and perceived access to treatment. Within broadly, so this system, what it does is that we collect from the substance abuse treatment system, so for each individual participating facility, and we generate reports for that facility and compare performance on these indicators against the average performance, and then we generate also a provincial picture. We've had 3 implementation periods, and we're moving into our 4th implementation period now. Generally, as in, I think, many performance measurement systems, the ratings in some of these indicators are quite high, but the rating on the indicator for perceived quality of services is one of the lowest ratings. So we're working with facilities to try and understand how we can improve this. And then that system, once we have a quality improvements initiative underway, that system can be used to evaluate the impact of quality improvement. So for treatment satisfaction, we've also used various scales in other studies to explore satisfaction with treatment, and it seems to vary depending on where you go and what kind of treatment you receive and who you are as well. So funnily enough, women seem to have quite high levels of treatment satisfaction. So once they get into treatment, they seem to do fairly well in treatment, at least in our setting, and they seem to be quite happy with the treatment that they receive. But people who are less satisfied are men, and then also people who are not, people of Black African descent, who generally don't speak English, and then the programs that serve them are English oriented. So there are very few programs available in vernacular languages.
I think we should probably stop there.
Okay.
So we have the time. Thank you.